This is Dr. Shaikh from Miami, Florida, and today I'm going to talk about two historical landmark studies comparing primary anastomosis with Hartmann's procedure in perforated diverticulitis. The first study is a seminal paper by Hinchey and colleagues published in Advances of Surgery in 1978, titled Treatment of Perforated Diverticular Diseases of the Colon. We know that diverticulosis is a uniformly ubiquitous disease and its prevalence increases with age. A variety of etiological factors are associated with its occurrence, and it manifests as abdominal pain, leukocytosis, and characteristic CT scan findings of colitis with or without perforation, depending on the state of the disease. Prior to 1978, comparative studies on perforated diverticulitis were hindered by the lack of a standardized system grading the severity of the disease. Hinchey and his colleagues presented a case series of 8 patients and extrapolating from their prior experience with this colonic affliction, proposed a standardized system of classification based on the degree of severity of the perforation. Stage 1 was localized paracolonic abscess. Stage 2 was extension of this abscess into the pelvis. Stage 3 was purulent peritonitis with increasing abdominal pain. And finally, stage 4, which was feculent abdominal contamination associated with rebound peritonitis and systemic manifestations of intra-abdominal sepsis. Military medical experience during World War II with abdominal injuries had established primary resection and Hartmann's procedure as the gold standard for the safe management of penetrating injuries of the colon. However, 20 years later, surgeons had started to question this dogmatic approach. Hinchey and his colleagues not only established a uniform staging system of perforated diverticulitis, but proposed that the operative approach should be based on the degree of contamination of the abdomen, as well as other factors like patient physiologic status, experience of the surgeon, and availability of good postoperative care. Stage 1 and 2 patients could be managed with primary resection, and higher stage patients were more likely to lead Hartmann's procedure. We then fast forward 25 years, and Salem and Flum at the University of Washington in St. Louis published their landmark paper in Diseases of Colon and Rectum in 2004. This was the first large-scale systematic meta-analysis which directly compared outcomes of primary anastomosis, also called the one-stage procedure, with Hartmann's procedure, also called a two-stage procedure, as patients would require a second operation for reversal of the colostomy for all Hinchey stages. They did a Medline search and identified 293 publications between 1957 and 2003, and then applying the methodology of elimination of low power or incomplete studies, they were left with 98 studies which directly compared outcomes of the two procedures. They also looked at outcomes of a relatively new procedure called PALE, primary anastomosis after intraoperative on-table colonic lavage, in an effort to decrease the colonic microbial burden, as these patients could not undergo a mechanical bowel cleansing prep prior to the operation. Their results revealed that for Hartmann's procedure, the raw mortality was about 19%, with wound infection rate of 24%, which was not unexpected due to the proximity of the stoma close to the midline incision, and that these were contaminated procedures. They also found reversal of colostomy, the second stage of this procedure, was a relatively safe procedure, with a mortality rate of less than 1% and anastomotic leak rate and wound infection rates of less than 5%. Looking at primary anastomosis with or without a diverting colostomy or ileostomy, the mortality rate was about 10%, an anastomotic breakdown rate of 14%, and a wound infection rate of approximately 10%. In those patients that had intraoperative colonic lavage done, the rates were very similar, showing no clear-cut advantage to performing this additional step prior to primary anastomosis. They thus concluded that primary anastomosis compared favorably to Hartmann's procedure for perforated diverticular peritonitis, with less patient morbidity, and this effect was more pronounced in the early stages of the disease. In the later stages of perforated diverticulitis, they proposed that since anastomotic leak rate and wound infection rates were higher, that if the one-stage procedure was planned, the surgeon should consider diverting the fecal stream, but that would necessitate reversal of the loop ostomy at a later date. The limitation of this study was that they looked at raw combined aggregate data and that differences in operative techniques, surgeon experience, and postoperative care were not adjusted for. This was also a purely retrospective comparative analysis, and that a wide variety of different studies were included. Nevertheless, it was a landmark paper in 2004 and set the stage for future randomized controlled prospective studies, which have largely confirmed their initial finding. Thank you.